On March 3, 1997, Dr. Jacques Himpens performed the first fully robotic laparoscopic cholecystectomy. He wrote, "I performed the surgery at some 10 yards away from the patient while sitting at the master's console." From that time till now, there have been great improvements in the field of robotic surgery. Surgical Intuitive, the current market leader in the field, reported over 14.2 million surgical procedures have been performed with their Da Vinci surgical system. But despite all these advances, one number has remained constant since that day in '97. 10 yards. Even today, surgeons make initial incisions, place instruments in the patient, and then walk to the corner of the room and robotically operate. But what if the surgeon didn't have to stay within 10 yards or 10 miles or even 10,000 miles? Telesurgery allows surgeons to work at a master console, controlling robotic tools that operate on a patient who could be an ocean away. With telesurgery, geographical constraints vanish, breaking down a barrier of worldwide quality healthcare. Telesurgery has the possibility to reduce costs, allow faster access to specialized care, and encourage global collaboration of surgical techniques. One of the barriers that is currently hindering laparoscopic telesurgery is the need for the surgeon to be physically present during the initial entry of tools into the abdominal cavity, also known as the peritoneal cavity. Entry into the peritoneal cavity is generally felt by surgeons, rather than relying on visual cues or instrumentation, making remotely accessing the abdominal cavity difficult. To solve this, the Terry Research Lab has developed the Robotic Automated Peritoneal Insertion Device, or the RAPID, which utilizes abdominal wall biomechanics to replicate the intuition and feel that seasoned surgeons develop over years of practice. It can safely access the abdominal cavity and act as a trocar for the insertion of instruments. The RAPID does this without any electronics by using air pressure. With the RAPID at the optimal pressure, insufflation, or the flow of air, will occur the moment the RAPID enters the peritoneal cavity. Once insufflation occurs, the RAPID then locks the handle to prevent damage to the abdominal organs. That precise air pressure is important because it must avoid too high of pressure, which will cause insufflation before the peritoneal cavity, prematurely indicating entry, and too low of air pressure, which will not cause any insufflation at all. So here's how it works. To set the device, pull the side plunger so that air fills the bellows, and then close the top plunger. This allows the bellows to be at a specified optimal pressure. A small incision is then made in the abdomen of the patient. The tip of the trocar is placed in the incision, and the handle is turned a few times until a seal is formed around the threads of the trocar. The top plunger is then pulled up, causing the air in the trocar to also be pressurized. Finally, the handle is continuously turned until the final tissue layer of the abdominal wall is breached and the bellows automatically expel the air into the abdominal cavity, moving the side plunger in and locking the handle. Now the trocar has been safely inserted inside the abdominal cavity, and instruments for robotic surgery can be placed in the patient through the trocar. The RAPID is simple to understand and easy to use. Anyone could operate it after 5 minutes of instruction. In order to examine the feasibility of the entry indication system, the RAPID was tested in live pigs, testing 24 placements total, with the results shown here. The image on the right is an example of what constituted a successful placement. This is the view from an endoscope inside the pig's abdominal cavity. At the same moment the trocar breached that final layer of tissue, the bellows collapsed to indicate entry. This work and this initial prototype have shown promise in automating the initial entry of the abdominal cavity. We envision that a motor and a feedback system can be incorporated into the RAPID to fully automate it, removing a limitation to telesurgery and global healthcare innovations. 25 years ago, surgery from 10 yards away was revolutionary. Now we are one step closer to 10,000 miles. Thank you.